Beautiful and full of challenge, and every day in our life we need to tackle a lot of challenge, but the challenge is worthy when it's something newer things come out, and that brings the smile and hope to the patient. Ladies and gentlemen, respected panelists and audience, very good evening. I'm going to tell the story of a 75 years old pleasant gentleman who presented with breathlessness on exertion, chest pain on exertion, mild exertion, and history of AVR 12 years back. Patient was hypertensive, diabetic, having CKD, creatinine level 2.4, and patient was also suffering from COPD. And his echocardiography revealed there is a high gradient across the prosthetic bulb. The gradient is 109 millimeter of mercury, that is the peak gradient, and mean gradient is more than 80 millimeter of mercury. And the patient have mild AR, having grade 3 diastolic dysfunction. Ejection fraction is 45%. So we are dealing with a case of 75 years old gentleman who has been suffering from biprosthetic aortic bulb restenosis, who have lot of comorbidities like hypertension, DM, CKD, and COPD. And his STSD score is 6.63, which he belongs to the moderate risk group. And I'd like to mention here that the patient previous surgical experience was not that soothing, as he has got some post-operative complication and take longer time from recovery. So he had some denial from surgical operation this time. So what should be the good option for this patient? Should he go for a redo surgery? But the risk of redo operation is higher than the first operation. The higher mortality and morbidity compared with the first time AVR involve more complex procedure, and frequently at advanced age, like our patient, have relevant comorbidities that may increase the operative risk. And therefore, not only the patient, but also the caring physician may be reluctant to operate for giving the option for reoperation until symptoms become very severe. For this patient, TAVR might be a very attractive alternative option, TAVR bulb-in-bulb, which is minimally invasive fashion without the need for cardiopulmonary bypass. And the TAVR provides a perfect, the previous valve provides a perfect circular platform to allow even expansion of the transcatheter heart valve, and it also provides a perfect anchoring tools for the TAVR valve. And it is obviously a shorter duration, procedural time, and can be performed under conscious sedation with a general anesthesia. And the patient recovery time is very early. Patient can be discharged from the hospital within 3 days. And if it is done by the experienced operator, the TAVR procedure might be a very soothing one for this patient, like the diagram showing in the slide. So the animation is showing that is the TAVR in bulb procedure. And the world, in the last two decades, we are seeing that the worlds are moving towards the TAVR procedure, and lot of patients going through the biprosthetic bulb in their early stage, who later on presented with a biprosthetic bulb restenosis, the bulb-in-bulb might be a good option for this patient. And partner bulb-in-bulb registry also support this evidence. And the VIV TAVR is also associated with lower rate of 30-day mortality and major bleeding, but higher rate of severe patient prosthetic mismatch. And the meta-analysis of the 6th study also shown, despite higher predictive surgical risk of bulb-in-bulb patient, there is no difference in mortality, but less PPI and dialysis compared to redo TAVR. But the operator must have a detailed understanding of the anatomy and fluoroscopic appearance of the surgical bulb. TAVR design, as not all the TAVR bulb are the same, the correct sizing of the bulb, the ideal implantation position for the chosen bulb within the existing saver bulb. And the specific challenge is coronary obstruction, especially in the case of a stainless bulb, TAVR migration and embolization, and higher residual gradient. So a very meticulous CT analysis of the aortic bulb is needed before TAVR bulb-in-bulb operation for the analysis of the structure of the aorta, ascending aorta, aortic bulb, as well as the proper sizing of the TAVR bulb. In our case, this is the slide of our case. Here, the rim of the, we have to detect the true internal diameter of the surgical bulb for proper measurement of our TAVR bulb. The inner diameter was 20.8. As the patient have pericardial bulb and the leaflet is mounted in the inner, so we have to add 2 millimeter more. That is, our predictive bulb size is 22.8, but we took 1 millimeter size over. That is, we predict the bulb size would be 23 plus from the CT analysis. And then from the CT, we also can delineate the implantation view, that is the LAO 19 and cranial 14. And we also can assess whether there are any chance of coronary obstruction by VTC distance. In our case, the RCC VTC distance is 7, but for the left coronary, it is 3.8. Any distance less than 4 have chance to coronary obstruction. And we have adequate femoral artery diameter, aortic diameter, except few mild calcification. And coronary angiogram showing borderline lesion in mid-LAD and LCX. First of all, in our procedure, we did it in a highly equipped lab, and with our highly expert team, and our vascular and surgical colleagues are on call if there is any complications. First of all, the right side femoral axis was introduced, and the left-sided femoral artery puncture was done from right-sided guidance. Sorry. And then the balloon tip TPM placed from the left side and check stability with 180 pulses. Then the insertion of 7 French sheet to the right side, insertion of extractive wire, insertion of 9 French, and then subsequently 11 French sheet, and the insertion of the finally the Python sheet, which is about 15 millimeter, 15 French, and heparin 100 unit per kg was used. As from our CT analysis, we have anticipation there is a possible occlusion of the left coronary artery during the procedure. So what we did, we again checked the left coronary artery, and it shown the left main artery and LAD was within normal limit except few plaque. Then what we did, for the protection of left main during placement of and dilatation of the TAVR valve, we put EBO guide catheter non-selectively and encouraged guide extensor catheter into the left main deeply and put PTCA wire, keep PTCA wire into the LCX. And if any, and put another stent 3 millimeter into 30 millimeter length stent, just keep into the LCX to for the if any coronary obstruction happen at the time of valve deployment, so that we can protect the left main at that time instantly to pull back the stent and we can dilate it easily. So we just put the stent to keep into the LCX for just to prevent the prevent the left main occlusion at the time of device deployment. Then we cross the aortic valve with the AL catheter with straight tip Terimo wire, Then the step tip thermo wire was exchanged with a pre-sized sapphire, extra backup sapphire wire. Over this wire, we perform all of our procedure. And we took, this is the TAVR bulb, 23 millimeter diameter. And the size is determined, I showed already from the CT analysis. After introduction of the crimped TAVR bulb over navigator through the Python sheath at the thoracic outer level, flexing with the help of proximal shaft with rotatory handle in navigator delivery system. And we place it across the previous saver bulb. Once the position of the bulb on the second dense band at the level of the annular plane, here the annular plane is the previous surgical bulb is act as the annular plane here. And once they're satisfied with the position, start rapid pacing, wait for pressure fall, and then start deployment of TAVR bulb. Once the bulb properly inflated, then deflate, stop pacing, and check hemodynamics. And this is the final result after TAVR bulb deployment. And then we again check for coronary. The coronary was unaffected by the bulb. So we pull back all the system with a stent. And finally, we took a gradient across the bulb, which is less than 10 millimeter and is acceptable gradient. And the post-procedural echo was good. And the gradient is only 6 to 7 millimeter across the aortic bulb with no or minimal aortic regurgitation. And this is the first bulb-in-bulb case in Bangladesh. And we acknowledge our team headed by Associate Professor Pradeep Kumar Karmakar sir to introduce such a challenging and challenging procedure which gave benefit to the patient who are often under-addressed. So my take-home message is, bulb-in-bulb therapy is a rapidly growing alternative to a redo operation when treating degenerative saver bulb. In short, 4 steps should keep in mind. First step is identification of the degenerative saver bulb, including its model, size, even fluoroscopic appearance. The second step is to determine the type and size of TAVR bulb. Third step is to assess the risk of coronary obstruction. Finally, the route of approach must be carefully planned. Once these aspects are addressed, the procedure can be performed efficiently with a low risk of complication. So the future is to bulb-in-bulb in TAVR, and this is, I don't say this is the end of redo saver. Redo saver is limited for limited option, where there is a chance of coronary obstruction is higher or there is a very narrow aortic route. Otherwise, most of the case, we can treat this sort of patient with bulb-in-bulb TAVR. And the future is TAVR, bulb-in-TAVR, or TAVR surgery, then bulb-in-bulb. Thank you so much for your patience hearing.